Welcome to the Living Medicine Podcast, where we talk about ethical medical use of psychedelic psychotherapy, teaching skills, examining the issues, and interviewing interesting people. Now let's start today's show.
Hi, everyone. This is Sandy Newis of the Living Medicine Institute, and we provide content and resources and training for clinical and medical providers who are interested in either launching a career into ketamine-assisted psychotherapy or deepening their existing skills. And we also have a broad interest in psychedelic medicine in general and psychedelic-assisted psychotherapy. And I am thrilled to be with Dr. Phil Wolfson, who is really very clearly one of, if not the kind of identified elder and wisdom keeper in the field. And Dr. Wolfson, actually, I forgot to get your written bio, so I'm just going to wing it. So you can fill in if I miss anything. Dr. Wolfson runs a longstanding clinic in the North Bay area where he treats a variety of different clients. He has a group practice, and I believe that you offer both ketamine treatment and CAP. Is that correct?
I don't differentiate between the two.
Okay. And also, he wrote kind of the founding book called The Ketamine Papers, which everybody has on their library, which really, in my opinion, really launched the field into being a field. And he's also really invested in research, and so runs Ketamine Research Associates. Is that the right way to say it? Normally, I have all this written out.
The parent organization is the Ketamine Research Foundation.
Right.
And
yes.
within that, we have two groups, the Ketamine Training Center and the ongoing Ketamine Psychotherapy Associates, of which you have been delightedly a part of.
Right. Yes. And I have had the privilege of being a part of the Ketamine Psychotherapy Associates, which I love and think everybody should be aware of. And it was also able to be with you at Dharma K, which was a kind of retreat style gathering at Menla that you all are doing annually. And I'm also aware of the fact that you two also do training. So we are, delighted to have the opportunity to talk with you and to talk about all of those things. So thank you so much.
Thank you. And call me Phil, please.
Okay, I'll be happy to. All right. Well, Phil, so being kind of, one of the elders, and I mean that as, the holders of the wisdom, not just age, but you have certainly ridden this wave, right? Ridden the wave of, psychedelic movement as it came into its inception and where it is now. And so what I thought I'd love to just start with is kind of that, like your history in the field. And then let's move into some of the things about ketamine and CAP in general and, what makes a good CAP therapist and, kind of some of the differences in routes of administration. So how did you get to be here? Like, how did you land in this place where you're so clearly mission driven in this work?
Well, you've been very complimentary. It's delightful to be with you and whoever is on your show, and I'm pleased to be here with them. Really, Sandy, I am. I wear the cloak of being a psychotherapist, and that's always been my delight. So when I was in college at Brandeis, and I had the good fortune of having access to psychotherapy, going through my own identity crisis at 17, we skipped a year in New York City, and we were very young coming into college, and it was 1960, and things were just emerging.
Right.
I had the opportunity for 30 sessions for free of psychotherapy. And given the severity of my identity crisis and my suicidality and all the stuff that went along with leaving a very imperial home with all of its difficulties, abuse, etc., psychotherapy really provoked a sense of a method that enabled me to find myself bit by bit. It went on for a long time after that, but it opened the door to resolution of some of the ways in which I was split and having the difficulty in finding my own path.
Mm-hmm.
I was very interested in history for many different reasons. I decided I was going to go to med school, and the psychotherapists, psychologists at Brandeis all were complaining that they couldn't prescribe, though they were at the forefront. Maslow was one of my teachers. They were at
Really?
the
I did
forefront
not
of,
know that.
yeah, they were at the forefront of progressive psychotherapy.
Yeah.
So med school, I decided I wanted to be Che Guevara for a while and did all kinds of radical stuff and organized the first health brigade to Cuba in 1968 and did community service in New York against the two standard of class care and racist care and misogynist care that was represented by being in Bellevue Hospital and then alongside it, University Hospital. And the contrast was horrendous. And the
Mm.
treatment of people who were not able to afford private care was horrendous. So I became very involved in all of the social justice aspects, Medical Committee for Human Rights, the streets, the 60s. And in 64, when I started medical school, uh, I and 8 other uh, men, young men, all dropped acid in New York City on the rooftop of our dormitory, thinking we could fly. No one tried it.
Nobody can fly.
Nobody could fly.
We just need to be really clear, people. Nobody
Nobody
can
could
fly.
fly.
Humans cannot fly.
And that was a pretty radical thing to do. And I don't know that LSD fully changed me, but it opened certain doors of conception. And what really helped was marijuana, which
Mm,
came in the same year and freed me a bunch of my self-consciousness. So
mm,
while I was really focused on um, radical ways of developing family therapy, systems therapy, as I graduated from med school and in fact did therapy while I was in med school. I was devoted to med school and to being a doctor.
yeah.
And the psychedelics played a small but significant part in that. But it was really the halcyon days of family therapy, Langian uh, ethos, and I ran a small inpatient hospital, an alternative hospital, when I came to California in
Mm,
'77, which was a process hospital. It was called I-Ward. It was funded by the county, and we had a kind of collective of anti-racist, very mixed, wonderful people. And the unit tried to show that we could treat first break people, schizophrenia or whatever, without use of significant medicine in a family-centered community environment. We were partly successful. It was
yeah.
a 20-bed hospital in the county system. It was difficult. Uh, and out of that, by 1983, I was looking for some other solutions, and I met Alexander Shulgin, Sasha Shulgin,
Uh-huh.
who was really the father, the reintroducer of MDMA, and
Uh-huh.
probably the most brilliant creator of psychoactive substances, phenethylamines and tryptamines, and we became very, very close
Oh,
and
nice.
very close friends and collaborators, etc. And that brought together a lot of the people that you know. So if I'm an elder by age, which I am, plus in part some of the other elders in Asia, those who are still around, many have passed on, formed an organization called ARUPA, the Association for the Responsible Use of Psychedelic Agents, that met at Esalen under the umbrella of Dick Price, who was co-owner of Esalen and unfortunately died in an accident up the mountain.
Mm,
We lost that support at Esalen. But
mm.
for a significant period of time, we were able to go to Esalen for weeks at a time. And a
Wow.
lot of what's still out there generated then, and a lot of what we learned, for instance, about MDMA,
Yeah.
generated during the legal period. And
That is so interesting. So tell me more about that. Because I had the privilege of hanging out with Sasha a bit, Sasha and Anne here and there, and the various brilliant people who circled them. And I can only imagine that being at Esalen during the time of legality with what sounds like was essentially a think tank, like
Was
pretty
it,
smart
uh,
people coming together to explore ideas, that must have been really rich.
well, it was an experiential think
Yeah,
tank. So
right.
people like Claudio Narano, Rick
Mhm.
Doblin was part of it, George Greer, who went on to after Dave Nichols, the Secret Chief, a
Yeah,
lot of people, a lot more people who were really invested. And Ken Blocky, who did Heading to Omega, and a lot of
Mhm.
stuff around near-death experience. It was a very rich experience, and we did a lot of therapy. And
Yeah,
of the uh, myths that people are living with now, for example, about psychedelics and MDMA in particular, are just that. They're not based on anything but the illegalization that occurred in 1986, and
right.
that led to the truncated, constricted way in which we finally have moved towards prescriptive legalization. But
Hmm.
that has all kinds of myths. So, a myth, for example, is that you can't use MDMA more than 2 or 3 months apart. No, MDMA is very successfully used a week apart, for example, with integration in between for couples therapy. A
Yeah,
lot of what we did was relational issues. We
right.
treated depression, PTSD, OCD, uh, families. I wrote a paper on treating families in 1986. It was published. So, and a lot of the methodology, which was revolutionary in its nature, based further on the LSD work, but MDMA as a really a perfect psychotherapeutic agent, I would argue,
Interesting.
along with ketamine in its various ways, especially
Right.
the low dose, as a perfect psychotherapeutic agent. The revolution was you had to be more alive with your patients, you had to
Mm.
be more expressive and exposed, you had to spend much more time. And while methodological frameworks were important, what was most important was kind of the integration of the experience, that being still probably the most important aspect of a post psychedelic session experience leading to psychotherapy output. And we did a
So,
lot
so
of
let
work
me ask you,
around
wait,
it. Yeah.
so if you want to finish that thought, go for it. But I just want to, and I want to just see like, I'm just sitting here being like, oh my gosh, what a profound personal and professional experience. And I'm just super curious, like how that influenced like you as a human and how you went on in your professional career. Like to have the opportunity to deep dive like that. Not a lot of us get that. Like
Well,
intentional deep dive.
I
Hmm?
had an intervening awful difficulty that came at the same time. And
Hmm.
that my oldest son, Noah, at 12 and three quarters, got ALL, acute lymphoblastic leukemia, and
Hmm.
life was threatened, and eventually he died 4 years later. So
Hmm.
in the same period where I'm doing all this, and my both my kids went to Esalen for periods of time, Noah was terribly stricken, and his life hung on edge much of the time, and eventually it ended.
Hmm.
So that MDMA was also an important personal part. I wrote a book about it, and
Yeah.
we did MDMA sessions, my wife and I, with
Hmm.
its awareness. I wrote a paper for MAPS in those days on, I'm blocking the name, but about being open as parents and not hypocrites in terms of how we deal with our use, not exposing children to use like an LSD experience, but to use like an MDMA experience. We had family time. They didn't involve themselves, but there was a centeredness and a cohesion that
Yeah.
occurred with it that was, part and parcel of what I was doing with other people. So
Yeah.
it set me it set me really into the whole thing about both grief and love and many experiences after that around grief and helping people who are
Yeah.
losing people or potentially losing people, which I still do, as well as the methodologies of using psychedelics. But of course, it went underground, and
Right.
and we lost it for no good reason, for terrible reasons actually, and we're only in a very convoluted way getting back to it. So we
Right.
can talk in this talk. It's always worthwhile to talk about the deformations of illegalization,
Yeah.
which is what dominates our lives and makes our attitudes and views kind of off in some ways from what they should be. Because
Right.
illegalization makes us think that, for instance, MDMA is only good for PTSD, or
Right.
ketamine is with Spravato is only good for TRD. But psychedelic medicines are about consciousness and
Yeah.
consciousness enhancing when they work well, and they're
Yeah.
about mind expansion, and they're about freedom from obsession and rumination, and they're about freedom to expose oneself to new feelings, ideas, and internal recognition of imbalance, and to accentuate what we have in us as a guide. So the
Mm.
role of the therapist can be very constricted. Oh, I'm doing CBT and I'm really locked into that. But in the world of psychedelics, the opportunity is for those things I've mentioned. And that's the excitement of being a psychedelic therapist. Miracles do occur fairly frequently. They're not always easy, some are hard won, but they do occur, and they occur much more rapidly on average than conventional therapy. And the life of a therapist doing psychedelic medicine, I think, is much more enhanced, much more exciting, and uh, and I think people like myself are still doing it. I'm 81,
Right.
and I love still doing it.
Right. I
Yeah.
think that is such an interesting thing that you just, and we could spend hours on this. So but I just spoke to Dr. Keith Heiserling from the TRIP Center. He's at the Pacific Neuroscience Institute. He's a psychedelic researcher. And I spoke to Dr. Ron Siegel, who I know is a friend and collaborator of yours. And we were talking about the same thing that's, you know, the relationship between like healing as defined by the scientific methodology, which is largely symptom reduction. And yeah, I was trained as a psychotherapy outcome researcher. So, you have to use symptom reduction kind of as the guide. But, within that, you can build in all of these other constructs, but there has to be some objective measurement, which I think is a piece of what you're talking about, that we then lose, things can get too mechanistic. But psychedelics have opened
Why
up the,
do
Hmm?
why does there have to be objective scientific measurement?
Well, in
Well,
order to get something
well,
validated and re-legalized, right? Um,
but most of it, see, this is the construct I'm talking about. In fact, there are maybe 50 million people, 3 million new users of MDMA. We
right.
know from emergency room visits that, it's very infrequent that people come in
Mhm.
with panic attacks. They don't
Right.
come in with safety issues. Why do we always have to show safety issues for 100 people or 300 people when we have 50 million people who have been safe on
Right.
multiple users?
Right.
So the evaluation is unfair. If you did the same evaluation in a legal period without all that scientific mumbo jumbo, and you extracted what was science, that would be interesting. But
Right.
most of the issues are covered without the academic, stamp of approval. They're
Yeah.
covered because people are successfully and safely using these medicines. So
Hmm.
just I'm just hammering at you a little bit around that kind of concept, because while it serves academic medicine and it
Right.
serves publications, it doesn't really serve legalization or consciousness raising or the ability of people to obtain these substances.
Well, I'm with you on that. I'm just, I'm kind of just pretty intrigued at this line and, how we do good science and good research yeah, I did wilderness therapy research for a chunk of time, and there's a lot of parallels. But the piece I want to kind of zero into here is that the role of, consciousness expansion, the role of shifting consciousness, and then how that relates, like what are your thoughts about that? Like we all kind of talk about it, but how can we as clinicians and medical providers really, do a better job of facilitating that while also kind of holding on to some of the mechanistic pieces that are mandated to us and do good work, right? I mean, how do we do the best healing work that we possibly can? Or if we go beyond healing, how do we shift consciousness? How do we do
Well,
it?
remember, we're really constricted because we only have ketamine as the only
Right.
legal medicine, okay?
Right. Yeah.
And if we take ketamine and the way it's being applied, administered, um, there are a lot of people who are not interested in going deep into themselves. And a lot of
Mm-hmm.
people who just want to seek, for cultural, personal, and other reasons, a drug experience like a ketamine and an experience in an IV center. It's pretty hard for someone to get away with that in an MDMA experience. You can do it. There are a lot of people who drop acid, who drop this thing or that thing, and who really don't take time to process or don't have the opportunity to process with people where they can explain and experience what happened to them and have a notion of someone interested sharing, etc. We
Right.
feel that that integration aspect, the sharing aspect, for most people is a very important part of healing. And when
Yeah.
you look at the statistics for IV ketamine, for example, and you look at McInnes's meta-analysis, 29.7% of people in a significant course of IV ketamine have remission. That's well within placebo. If you look
Mm-hmm.
at the approval that Spravato just got now for extension into major depression from not only TRD, their experience was under 30% with a 7% placebo response. So
Hmm.
when we look at unsupported uh, psychotherapy, non-psychotherapy treatment with substances that are mind expanding but used in a drug setting, we
Hmm.
see very little. Uh, 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 Let me put it differently. We see a poor correspondence between outcome and the drug experience itself, and
Right.
and the nature of the drug experience is not just drug. So that's another mythology. The nature of the drug experience. Yes, we think ketamine, for example, MDMA, for example, are medicines that have experiences on mind. We know that. They
Yeah.
mess up neural networks. They do all kinds of weird things. They suppress the one network and expand another. They're all over the map. That's why they're different. At the same time, besides the actual uh, neurochemical scramble, I call it a scramble of mind and brain, because
Uh-huh.
it's a various scrambles that occur. If we look at that, we can also see the properties. There's a psychological property to ketamine. There's a timeout. If you don't get some reduction of who you are, your ego, you don't get a ketamine antidepressant effect. The
Hmm.
psychedelic effect of ketamine is totally linked and maybe even on the same receptor site. There's evidence for that. So that there's a balance between what may be a drug effect and what is an actual emotional psychological effect of
Hmm.
relief from who you are for a little while. It's
Yeah.
like an ECT, a shock therapy with consciousness, and the
Right.
whole reason that shock therapy was explored, sleep therapies with and barbiturates were explored, was to take people and give them relief from who they were for some time and scramble their brain up, which shock does, including your memory, and
Right.
bring you back so maybe you won't start at the same place again.
Yeah.
Really
Yeah.
the essence of it. And so with ketamine, that is the essence of what happens even in IV settings. You may have psychedelic experiences, most people do, but they're unprocessed in most IV settings. And
Right.
you can process them, but anesthesiologists who run much of them don't do it. So you have this time out and you have a bit of relief from who you are, from all that nutty
Yeah.
concentration, rumination. I need this, I need that, I hate this one, I love that one, why don't they love me? All that stuff takes a little break. And
Yeah.
then come back, and people who are very rigid and tight will come back often at the same place. But most people come back somewhat different, renewed. There's a bit of, okay, I'm different. With MDMA, the process is different. That's a ketamine process. With
Interesting.
MDMA, the process is watching self and allowing new material to surface more easily that's repressed. So MDMA is a wonderful agent for evoking trauma, repressed material. Ketamine does some of that if you prepare and you work with it at a low dose. Well, that was
So
a
did
long.
you go from, I mean, did you, so, you've done a deep dive into ketamine and have been in it for a long time, like seemingly as long as almost anyone. And is that because of the legality, or did you think or did it kind of capture your attention in other ways?
Well, I mean, I first had my ketamine experience in 1990. It was probably, even given my history, one of the most powerful things I ever did.
Yeah.
People who administered it didn't know what they were doing. I was sick for 3 days, nausea and vomiting, but I had a profound experience.
You're like, this is great.
First quarter,
Let's do it
and
again.
I'm a Buddhist guy,
Yeah.
so I'm always looking at non-attachment. And what I felt in it and still see, I can still see the experience was my leaving this body and becoming an energy format, and the way
Mhm.
in which that visually was expressed, because ketamine at high dosages is a visual experience, internal visual experience, not related to external senses. And
Mhm.
there's a guide, there's a commentator watching, and you watch the whole thing. If you're not able to watch it, you're anesthetized. You've gone too far, taken
Yeah.
too much medicine. But if you watch it, there's all this stuff. So I thought I'd already had encounters with death, lost a child, and so many others, parents, etc., and patients. So I felt, well, I had an experience that seemed like death. I think anesthesia is much more a model for death. But I had
Yeah.
that experience. I didn't need to have more. And I think that's important for people to understand. You don't have to do it again and again and again. You have
Right.
to experience and value what you did. Okay, along comes a group of my colleagues, friends, and we form a group, and we've been together for 25 years
That's
as a
amazing.
psychedelic men's group. And
Yeah.
I learned ketamine again. I
Yeah.
picked up some 10 years later, amongst others, and it seemed to me to be a profoundly interesting, a profoundly changeful experience, particularly in a good setting. All psychedelics require a good setting. Don't do
Right.
it where you're going to have paranoia and get in trouble. And I
Right.
felt that it had clinical merit. And
Yeah.
so I began using it slowly in 2013. And then in 2015, we started our clinic. The same
Mm.
time, Raquel Bennett came up with the first PRIA conference. And that was interesting because at that point, I was saying uh, publicly that you needed to have a full psychedelic experience for the antidepressant effect. That was really wrong. I
Mm.
once retracted it. And at that conference, kind of a changing event was a man who came on Zoom uh, from Tasmania, Stephen Hyde, who had just self-published the second book on ketamine called Ketamine for Depression. And
Yeah.
Stephen had had the foresight, wisdom to use ketamine orally, which is what he could do in Australia. And he said very definitively, there's no reason to go through the medicalization of putting people with IVs and monitoring them and doing all that stuff. It's totally safe at low dose. It's safe as an anesthetic. And let's do it in the office. And he was very explicit in
Yeah.
saying this is an office-based practice accompanied by psychotherapy. It was really convincing. We brought him to the States. He's a wonderful elder. And that really shifted the practice into two camps, the anesthesiology and academic psychiatry. IV camp, who was still in the war on drugs, afraid of psychedelic experience, which they couldn't control anyway, kept the dosage low. It's since expanded in amount to be more effective. And the camp of us that saw it as a psychotherapeutic tool, which we've been developing over time with many, many methodologies, nothing that's totally specific. No one methodology fits everyone, whether it's internal family systems or it's self work or it's psychodynamic. The best thing is to be a people worker and know your person and try and work with where they're at and find the good qualities in them that you love and respect.
I love that. So back to those humanistic roots.
They just left.
Yeah. Yeah.
Why would they leave?
Well, I'm not saying they left. I'm just saying, like, it's clear that that's really foundational in the way that you think about psychotherapy.
I think it's foundational the way we think about humans.
Right? Right. Agreed. I agree with you. It's just, it
If
sometimes
we're
gets
not,
lost.
if we're not for kindness in this world, what do we have? War, degradation,
Right.
monsters running countries, nuclear war. What do we got? Let's be
Right.
clear. If we
Right.
don't, if we don't foment kindness in our
Yeah.
own self-exploration, in our being in the world as therapists or people, what do we got?
Well, it's interesting because in our training program, I actually tell people I did one of my favorite parts of being a CAP clinician. It is I get to just be really sweet to people. Like it allows me to be just really nurturing and kind and really sweet. Like I'm right in there in their bubble with them, being like super nice, and intentional, but I'm like holding them in this bubble of just like, I got you in a sweet, loving, kind way. And that's really transformative for me on a very human level.
But I'm sure, Sandy, within that sweetness that you know, slaver people with, that there's also an intensity of concentration around
Oh, for sure.
the issues are, and that's an envelope within which you work, which is
Right.
the most successful envelope in psychotherapy by all measures. That,
Right.
you know, kindness, sweetness, acceptance, and um, thoughtfulness towards the human beings we sit with or are with in our treatment is the most successful uh, measure of outcome, most
Right.
successful input.
Well, and then if you can also be a really good therapist, good clinician with, good assessment skills and, good understanding of theory so that you have a sense about where things might emerge next and how to intentionally use the relationship and some good interventions, then all the better. But I think, like the package is really where it's at. And that's what appeals to me on just a human level, is that it allows more of just the kindness and nurturance to just emerge. Um, so I'm
Well,
curious.
you're also saying how interesting it is to be a therapist and what an amazing learning curve there is to learning about yourself and
Oh,
learning
yeah.
about human beings and social aspects. I mean, it's it's a scholarship to self-awareness.
Mm,
Never been there's never been a profession like our profession
right.
historically. Rabbis, priests sort of come close, but not really.
Can I write that down? There's a scholarship to self-awareness. That's awesome. I love that. I love that. So, a couple things I want to ask you specifically about CAP. One is, And we can kind of go in whichever direction. You keep saying like low dose versus high dose, and I'm curious. First of all, I'll just ask you that. When you say low dose, what's the range? And when you say high dose, what's the range are you referring to? Because I think people mean different things.
Um, I don't know if you want specific numbers. I'm not
I
sure.
do actually, because I mean,
I
people who are
just,
listening are curious
I
about
just
that.
finished the guidelines that we're going to circulate, two guidelines. One
Mhm.
is for people who are using and getting in trouble and who
Mm.
are contemplating using. It's very detailed. And then
Yeah.
a second guidelines for what I view as the standard of care for clinical practice. And all
Hmm.
laid out. We're going to have an online
Awesome.
pamphlet of large, it's a big pamphlet, but
Yeah.
I think it's thorough. I don't know if I want to put it as numbers, but the hazard of numbers is that it doesn't speak to your or my sensitivity. That
Right.
how we, classically we do ketamine, for example, and some other substances as milligrams per kilogram.
Yeah.
And, that was lowballed in the initial ketamine IV world because they were so scared of people having dissociative psychedelic experiences. But it's really not about milligrams per kilogram. You're smaller than I am, and you might need more to have an effect. I'm pretty sensitive, and we
Mm.
see very small people who need a lot, and very large people who need much less.
Yeah.
So the issue with any psychedelic is what it does to your consciousness, what it does in terms of nausea or side effects, but mostly how you receive it and where the sweet spots are for benefit. With
Mm.
ketamine, the sweet spots are all over the map because the dosage is so flexible and you
Yeah.
can start very low. So some people are using ketamine a very small number of milligrams. We're going to use it basically as an intramuscular reference. So if you use the intramuscular reference, some people are warming people up for conventional therapy with, 4 to 6 milligrams, things
Mm.
that hardly feel. There is no microdosing, so please, if we have anyone listening, don't bother with microdosing ketamine. So,
That's not a thing.
yeah, so then you have what I call psycho-revelatory or psycho-revelation experience, which I put at 10 to 25 milligrams, where you can do it in wonderfully in groups, where there's a short period of being under a significant influence, depending on sensitivity. And you can do actual therapy, much
Mm.
like MDMA, in which there's an ability to interact and a softening which continues after the major metabolism of the dose is off.
Mm.
And then you go further up. Some people are very sensitive and can't do much more than 35 or 50 milligrams. I just did a small group in Malta of neophytes
Mm.
on that island. And, there were people there who had, were really sensitive. And they
Mm.
one who went too far and she came back and did a lower dose again and rectified her difficulty and was joyous. So, it's an art for one.
Right.
And, what you're really looking at is the degree in which you're leaving the room or you're dissolving your ego and you're
Mm.
getting into a meditative space. So, a completely meditative space is when your external sensory inputs are turned off. And
Yeah.
what's going on is your internal visual, mostly visual, somewhat you have to do music, but it's not always appreciated. Where you've cut off the outside and you're tripping. You're on a
Yeah.
journey. And ketamine journeys are among the most complete in terms of leaving any sort of relationship to this external world. Okay, for a short period of time,
Right.
25 minutes for the
Yeah.
major part, 45 to an hour for
Yeah.
the coming down and back. So, what is the value of that? Many values. One,
Mm.
it really takes you out of yourself and leads you as you integrate to an understanding of balance. It has very little reference directly to your life, but it can be, as you integrate when you come back, of great importance to who you are. If you're a depressed person and you go through this, ketamine reliably has an impact on emotion that's neutral to very positive. So we often say to people who come back who are howlingly miserable coming into a ketamine experience, then they come back smiling often and joyful. We say to people, don't think of yourself categorically as a depressed person. You just saw you weren't. So let's
Right.
open that door. Let's
Mhm.
open the door to not putting you into a box.
Well,
Because
that's one of the things that I see a lot. Like people have a felt sense of themselves as different.
yeah,
Like they actually have like a lived experience of experiencing themselves, experiencing me in relationship, seeing their lives differently. And people get into this like aha moment, like as if there's supposed to be just some insight, when really I think it's about the felt sense and the like lived experience of having something different actually occur.
well said. I agree.
Yeah.
Well, and we could go on. So there
Yeah.
are many more aspects to it. So the good quality of even before you take that great leap in terms of dosage and experience is really the sense of relaxation and
Yeah.
letting go of obsessional, ruminative,
Mhm.
concentrations, fears, you know,
Mhm.
obsession with fears. We are always generating obsessions and judgments, and they're in the background, prejudices, attitudes. People who carry trauma see the world through the lenses of their trauma to
Yeah.
various degrees. We created an acute PTSD trauma program with ketamine for people in war zones, which has been a little bit applied
Yeah.
because just the relief from the awfulness to come back to where your executive functions can override a little bit your reactive amygdala, your reactivity functions is an imperative for people.
Well, I teach that to every one of my clients, just about kind of hand model the brain, like I'm blanking on Dan Siegel's model and teaching people about that I find super useful. And I'll just put in a plug like post disaster, I did that low dose ketamine that you're talking about, that acute stress protocol, and it was awesome. It did exactly that. Like suddenly things seemed like even though it was really hard, we were making it. So I appreciate that.
Thank you so much. And that endorsement's important because we're not making people go very far into psychedelics. What we're doing is creating the potential for a bit of relaxation and
Right.
expansiveness with coping functions, which are present but overridden by the trauma, by the horror show, that those come back a bit, somewhat
Right.
back a bit.
Right. Well, and I know we could go on about that, but I mean, personally, I think that is one of the critical mechanisms. And I find it to be even more effective if I've educated the client about it beforehand, that
Yeah.
we're looking for that shift in state, right? That like shift in kind of an awareness that we're out of the ruminative state. Our body is calmer. We see our environment as different, as less threatening. And that helping kind of open the door to that, I think, is really where it's at, or one of the big pieces. So I love that you said that. So I want to ask you about, what do you think are really like best practices if somebody wants to be a good CAP person? And again, differentiating ketamine treatment and ketamine assisted psychotherapy. But I also want to put it in there, this piece about, we started here, like before we started recording, I would do primarily IV and I love it. And you do all IM and you feel very strongly about this. So tell me why you hate IV.
Well, let me correct you a bit. I don't do all.
Okay.
I do a lot of lozenger work.
Oh,
I
okay.
did the rapid dissolving tablets with our formulating
Okay.
pharmacies, which are all over the world. I often begin people with that as a dosage escalation.
Oh, okay.
Occasionally, I use intranasal. Um, but as I said about, uh, I've watched a lot of IV. I've
Yeah.
experienced IV. It's not that ketamine can't be experienced well by intravenous. It's the medicalization of it. I don't
Mm.
like that at all. I know
I
I
see.
watched just recently, we were in Barcelona doing a training of Europeans in ketamine work, and I watched a whole series of IV sessions run by a psychiatrist. And he had four people in a room, all sitting stiffly in a chair with no music and the drip going, and they weren't even communicating. They were just waiting for the experience to occur and get over. Um, Ketamine deserves to be processed. It's a
Right.
very powerful experience. And
Yeah.
letting people, as is the common practice, I'm sure not yours, being just in a room, a nurse administering an IV, sitting there, lying there, no music, no aftermath, 50 minutes elapse or even 40 minutes. The drip is over. You have a bit of recovery, you go home.
Yeah.
Okay, you may have some benefit. As I
Right.
said, it's about under 30% of remission, a little more for having a significant effect. But it's a powerful psychedelic, and we're creating a new world, Sandy. The new
Yeah.
world, which we've been trying to create now for many decades, which is not going too well, is a world.
It doesn't seem to be currently, does it?
Um, it's a world in which people are thoughtful about each other. It's
Yeah.
a world in which people are interested in who they are, how they think, their prejudices, intolerances, tolerances, needs, aversions. It's a world of inquiry and connection and of recognizing the interconnectedness of all of us. And that's what I see as being the essential work that I want to promote and that psychedelic medicine promotes. You wouldn't
Mm.
say the same thing about MDMA. You wouldn't say, oh, let's put MDMA people in a chair and drip in the MDMA. You would say that's against the nature of the heartfulness and consciousness arousal and trauma work that can be done with MDMA. I'm saying ketamine's the same.
Okay, so just so people know, like, because just to play, like, agreed, and like, because I work in one and I was trained in one, they can have an IV clinic, like where we have one person in a chair and the therapist is with them, and the prescriber and the, IV person comes in like once to set it and then like two times to check it. And I'm doing therapy the whole time. And personally, I think it's great because the state stays steady. But that's really different than what you're talking
That's
about.
another myth, okay? I'm going to argue with you. I agree on your basic supposition, but
Yeah.
I can do the same thing with multiple injections
Right.
of an intramuscular nature. I can start slow, I can add to it, I can do three of them. And the myth in the IV thing, which I'm going to take you down the road, is that, oh, IV practitioners have complete control of the medicine. That's baloney. An IV takes 10 minutes before the effect occurs because it has to drip in. Once the effect occurs and you're really happy with the effect, you turn off the drip. The person's still metabolizing the ketamine for another 10 minutes. The same thing is true with the IM. And the advantage of the IM is you're not sitting there stiff with an IV that some nurse has to put up you and you're dripping in. So, yes, you could make IV wonderfully useful to people if you wish to do that. And I'm glad you're doing that. But I don't think you would be hurt by switching to IM at all.
Probably not. I will say that my experience, my like both lived experience and what I have witnessed and seen is that IM goes for the way most people administer it. And again, maybe you have a more sophisticated way of doing it, but it kind of comes on like a ski jump, right? And then you're like, you hit full strength and then it goes down. And then you spend this part of the session processing this part of the session. Whereas with IV, it's more like this. So that's just, I'm open. I'm
And,
totally open to like changing my
well,
mind.
first of all, we have many, many strategies for
Yeah.
doing lozenges, which
Hmm.
only can be, and we do to have people go home with lozenges
Yeah.
under supervision, which really supports the work. So I
Yeah.
don't want to maroon myself in IM. And the
Yeah.
IM process, yes, it comes on quick, but if you use a low dosage, it doesn't matter. And
Mm.
for the IV. it takes time to shut it off just the same way.
Well, it's definitely more resource intensive, so therefore inherently often more expensive. Like that's a given,
Well,
right?
actually, ketamine-assisted psychotherapy, as you know, is much more resource intensive than having a nurse drop an IV into someone, leave the room, and they get dripped.
For
Uh,
sure.
that's
Right.
very, that's a gold mine for the people who do it that way. Put
Right.
4 or 6 people in rooms, you got the drip, the doc's nowhere to be seen, and they're getting the nurse there, and they leave in 50 minutes, next batch. People are making tens of thousands of dollars a day on that kind of stuff. And this
Yeah.
bravado thing is taking hold the same way. People are making fortunes on doing Spravato without really any processing. So
Right.
it's a drug. It's not a medicine. It's not
Right.
a consciousness tool.
Yeah. No, I'm with you on that. I mean, I share those concerns just with the idea, with also just the little bit thing like, and I think you can do effective cap at an IV clinic as long as you're attending to it. But I hear you that that is not usually the way that it's done. And I share that view like
Oh,
that.
I don't want to attack your livelihood
No,
here.
no, no, no. This is just a conversation. I find it fascinating. Like, I don't feel attacked in the slightest. It's just it's a different trajectory. And I'm actually, um, I'm
You're
open,
middle of the road. You're sort of the middle way.
right? Because what I do a lot of is the infusion series with CAP. So I'll actually do 6 sessions over 3 to 4 weeks while doing psychotherapy and preparation and integration. So it's a really intensive model. So we're almost out of time. And so I want to just ask you, what do you think? What do people need to know? Like, what are the best practices for CAP? And obviously, that's a 4 day training. I mean, I'm just talking about like, what do you want people to know? Like, if you're like, okay, people, you want to get into this field or you're doing this work, this is what you need to do to treat your patients well.
There's all the administration and technological issues of which are not very complicated of learning how to do ketamine itself.
Yeah.
People need to have doctors or people who really know what they're doing around ketamine. To pass it off as an innocent procedure that has no medical consequences, utility, or worthwhileness is a mistake. The more
Yeah.
people can practice a full psychiatric approach to people, knowing what meds are, medical interactions, um, and the core issues, more importantly, that people bring in which they're suffering,
Yeah.
which have all the social, personal, relational issues, knowing when to use ketamine as a medicine, knowing about its potential for diversion and
Mm,
its potential for cravings and dependence, which doesn't occur in the clinical setting, but is occurring obscenely outside the clinical setting. Uh,
great. I see that
and
too.
most importantly, since I'm a psychotherapist, emphasizing that getting to know who you're with and then being able to relate to it non-judgmentally, ethically, without needs of your own, and being sympathetic to that and helping the person learn themselves, know themselves, express themselves are the major points of view. Whether you do that with somatics, which are wonderful in terms of expressive thing, action before and after, you do it with internal family systems, which a lot of people are learning. You do it with psychodynamic psychotherapy, gestalt therapy, you know, I like to think I'm trying to learn it all. I never will, but I want
Right.
to be, I want to be as broadly uh, thoughtful as to what may reach someone
Mm,
better than another. And what really reaches people is that you find with someone you're seeing something that you value. And
mm,
when you accentuate that value in them, you open the door to them building trust. So the
mm,
core issue of doing any of these kind of experiences, including conventional psychiatry, psychotherapy, is the building of trust. And because people are coming to you and having a profound experience to whatever degree, they are saying to you, I trust you with my consciousness, with my being, with my life. And you, as a therapist practitioner, want to deserve that trust. It's not easily given. It's often fraught with defensiveness and a process before someone yields to it. But the core trauma of human beings is the breakage of trust, loss, the grief over all of that, and the ways in which we harbor distrust and see the world through lenses that we don't always recognize as distrust. So, what we're trying to help people do in the best way we can is establish some sense of personal self-trust, awareness of how one's been hurt and how one is responding to that, and being able to become more flexible and develop ways in which you can work with yourself to provide sharing, love, connection, and a deep experience of learning and appreciating yourself and others.
Mm. That is a really beautiful translation of some really complex concepts. I can appreciate your skill as a translator, being able to translate the complexities into just human terms. And I thank you for that.
Thank you.
Well, and that, so I think that's a lovely place just to kind of put a pause there. But what else do you want to share? Like, what do you want to share about yourself, or what do you want to share with the audience or the psychedelic world or the clinical world? Like, what's your message? What do you want to get out there?
I have only one message.
Uh-huh.
There is only one way forward, whether we call ourselves psychotherapists and we're reactive to the traumas happening to people, and we're not prophylactic. We need to also be prophylactic against the causation of trauma, whether that comes from misogyny, racism, inequalities, lack of sharing, cruelty, greed, aversion, whatever it is. We need to develop our awareness and our ability to both exemplify and help ourselves and others to share, be kind, love, and show concern for others. It's the only way forward. We are living in an increasingly cruel time with cruel people running lives, and that's abhorrent. And I don't know how it's going to work out, but I do know that the only antidote to that is not being that way.
Right. Yeah. Yeah. So let's earn trust. Let's not be cruel. Let's be good humans. Yeah.
I hope I wasn't cruel to you about the IV thing.
Oh, no, I didn't feel that's cruel at all. That's a professional discussion, and it's useful and interesting. And, I find it quite fascinating, the whole thing. So yeah, no, that did not feel cruel in any way. That felt like a professional discussion. So, all right. Well, anything else you want to share?
Yeah, great gratitude to you. Thank you for having me.
Good. Well, and let me also just give it, once again, for people who are interested, Phil and his team do training on ketamine through KTC, the Ketamine Training Center. You can also connect with him through Ketamine Psychotherapy Associates, which is a group that meets every other week, where we do some case consultation and discussion. And then there's the research group, Ketamine Research Associates.
No, it's the overall umbrella is Ketamine Research Foundation.
Right.
And you can get to anything that we do, including our clinic.
Good. So you can reach him there and the clinic. And I am just really grateful and appreciative. And thank you so much for sharing with us. So, all right. Thank you, Phil.
Welcome. Thanks.
Thanks for listening to Living Medicine. We'll see you again next time. Be sure to click subscribe to get future episodes.